Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Before we get started, I just wanted to remind those of you who are working on backlogs, just check in the www.chartingcoach.ca/backlog-buddies is the place you can come and do your backlog alongside fellow clinicians and physicians. So if you want to kind of hang out and have some ability to stay on task for the 2-hour sessions, come along. We'd love to see you there. Good morning, everybody, and welcome back. So I was having supper last night with some vets and some a pharmacist and a physical therapist in town. And I had invited them over because 3 of them were brand new to the community. 4 of them were brand new to the community. And so we just wanted them to be able to connect because it's nice to be able to make connections. And as we were chatting, up came the topic of charting because, you know, that's what I do. And it was so fascinating. Pharmacist hates documentation, would rather do it on paper and have it scanned in. Physical therapist doesn't like, has an EMR, but doesn't enjoy the charting. I didn't kind of dive into her charting habits right now because she's in the middle of exams and that would be rude. And then the vet, we're talking to the young vets. And so my colleague vet, who's similar vintage to me, she remembers taking many charts home at the end of the day to get done at home while watching TV or whatever. They just switched to an EMR and now they can't access that outside of clinic hours. And so one of the young vets was saying how she's just caught up and doesn't have a backlog anymore. And I'm like, why does this happen? Who let us get away with this leaving it till later piece? Why is this perpetual across not just physicians and clinicians, but vets and physios and pharmacists? Like, what is going on? So anyway.
But nobody trains us to do this, right? I mean, we have so much training on the knowledge we have to acquire as a healthcare professional, but no one talks about sort of the practicalities, the logistics, the nitty-gritty of how do you actually get a day. So I feel like there's certainly room for improvement in medical education to maybe not necessarily in medical school, but on our residency, wouldn't that be great to have that sort of training? Billing, coding, charting. As I said, you don't, when we're in medicine, you're taught about so many other things. And again, very knowledge acquisition, but what you do on the day-to-day is so critical and applicable to everybody, obviously, no matter what specialty.
No matter what specialty. So yeah, these are teachable, trainable, learnable skills. And so with that, I'm going to introduce Dr. Jane Kim. Thank you so much for coming. I would like you to take it away. Tell us all about who you are and how you ended up in this sphere.
Absolutely. Well, I'm a 3rd-generation physician. My grandfather was a physician. My dad is a physician. And so here I am as a 3rd-generation physician. I grew up in Kentucky and I went to medical school at the University of Kentucky. I decided to do family medicine because I love the pediatrics and the geriatrics, and I wanted a specialty to encompass that. And I like clinic outpatient medicine much more than, say, hospital medicine and the like. So I did my training in Arizona. I did my geriatric fellowship in Arizona. And then 20 years ago, my husband, who is also a physician, we moved to the Denver, Colorado area, and that's where I've been ever since. And so now I'm an outpatient geriatrician. I do get to work part-time, which is a huge, lovely thing. And I also do a lot of administrative roles within my physician group, which employs 10 physicians and 3 nurse practitioners. So, and we have 2 different clinic sites. And I absolutely love my job as a geriatrician. It's very rewarding They say it's a calling to take care of seniors. The visits can be very intense. So, what's nice about my particular practice is my typical appointment is a 20-minute appointment. A follow up or a complicated patient from a hospital stay is a 40-minute appointment. And then we have 1 hour for a new patient. And so, not to say that and when I hear other coaching calls and there's people who do 30, 40, 50 visits a day, that's mind blowing to me. But I can certainly say, given the structure and the complexity of most of my patients, there's a lot it feels to document that one must do in each visit. So
Yeah.
yeah.
How was the journey through that navigation? So you started in family med and ended up in geriatrics. What was happening within your day? What did you notice about medicine?
Sure. Oh, absolutely. So, and I remember when I started, it was paper charts, and I know that that's how old I am now, being 20 years in the business. So I remember taking home not necessarily the whole chart, but I take home blank pieces of paper with my scribbled notes on the side to be able to finish charting. I definitely remember those days. Then once the EMR started, and currently we have Epic in our clinic, I remember, again, I would have the medication list of the patient. I'd scribble notes during the visit, and that's what I would bring home and then chart from home on the computer. And I remember many nights charting until midnight. I have one young son, so it seemed like when I got home, it's all about family, dinner, bath, all the usual home stuff that we all experience. And then after he went to bed, it's time for me to start charting and being up for hours and hours and hours. And I certainly, like many physicians, have perfectionist tendencies. So I wanted my note to be pretty, beautiful, eloquent, articulate, going, and that certainly has some advantages, but probably overall has disadvantages as far as um, the length and time I spent. The encounter with the patient could be 20 minutes. I would spend 30 minutes finishing the note, which of course doesn't make any sense when you do the math of it, as you like to tell people to do. Um, and it just seemed like I had a lot of people pleasing. That is, I never wanted my patients to have to wait. I wanted to run on time. Not that those goals aren't good or, well intentioned, but the thought of my patient waiting in a room and waiting just for whatever reason made me feel very uncomfortable. So I prioritize being on time, or at least not running too late, versus getting my charts done. So it kind of all came to, I've been doing this for probably 18 years of that craziness,
Yeah.
which drove me crazy, my family crazy. But I remember a very distinct Saturday morning. I'm charting. It's 2 in the afternoon. I've been charting for hours, just trying to catch up on my Friday patients. And I look outside and it's a beautiful sunny day. And I'm like, what am I doing? This is insanity. This is crazy. Why am I spending my beautiful weekends in front of a computer instead of being outside and doing fun things? So I had this epiphany. I think I had seen something about you on Facebook or something, and I signed up that day. I was like, I'm going to change because I've been doing this for too long and I'm not embracing my life. And so I did that in January of 2022. So now 2 years ago. And it's been life-changing. I mean, truly, I listened through all the modules that weekend. When I went back to work the next week, I finished my charts all in one day. And I will say, prior to that, say maybe once every 3 months, I would literally finish my charts that day. I mean, it was such a sporadic, miraculous event. But then after listening to your program, I was able to do it every day. And I had a streak of like 3 weeks in a row where I didn't, I was able to finish my charts before leaving home. And then being human, which we all are, having a complicated clinic day. Um, for me, I can tell you what sort of prevents me from being able to finish patient chart, patient chart, patient chart are the interruptions, which I know, of course, you have a lovely module on. And because our clinic, most of our geriatricians are part-time, so most days I am covering not only my own inbox, but perhaps one or even two other doctors' inboxes. And of course, again, going back to the complexity of our geriatric patients, there's a lot. When you're covering another doctor, you want to do a good job. You don't want to break these frail elders with decisions that you make. So you have to read through the chart and you want to do a conscientious job. So that may slow down the workflow of my day. But again, you just sort of say now, instead of being, oh, why couldn't I finish? It's more like, today was a day that was a little more complicated. I took care of patients. It's okay that I have now one or two charts to do at home. At least now I live in a world where I don't bring all the charts home at night. So
Yeah.
yes, so I certainly want to say for other people who are dealing with charting, it's lovely when you have a day when you finish all your charts at home, and I hope for everybody it's 100% of the days, but let's be realistic. Life happens, patients happen, things happen, and at this point, I'd say I'm 95% of the day I finish my charts. There's 5% of days where I may not finish all my charts at work, but thankfully for me, I'm able to bring 1 to 4 charts home instead of 14, 15, 18 charts
Yeah.
home. So
What do you think the time difference is like now with that chart when you're doing it at home? What are you noticing that's different about what's now left in the note ready for you?
absolutely. So I do think what the thing I always get done, and I'm sure other people can relate, I always get my orders done, labs, referrals, things like that. I can do that while I'm with a patient because as a patient's talking, I can multitask and be able to order certain things, type out certain things. I would say though, aiming for the B- note has been extremely helpful. I think also, and I'm sure this can be applicable to a lot of physicians out there, we often code by time. So in the United States, we have certain evaluation and management codes where if you spend so much time with the patient plus charting, you can code by time. So with that, that's sort of a permission to say, okay, my HPI doesn't have to be as detailed. I, like many people, put a lot of attention to assessment and plan. But again, if you're coding by time, then if you were ever worried about an audit, if you have the time documented, then what's actually in the note is not as critical. And I also keep in mind that 99% of the time, the person reading the note is just me. There may be times my partners have to read the note, or a specialist or a hospitalist has to read my note, but it's for me. So what do I need to
Mm.
go from a past encounter to this encounter? And I don't need a huge HPI. I think we spend 20 minutes, 40 minutes, an hour with a patient. We've spent that energy. So of course we're like, well, I want to show people that I spent all this energy. And so I think there's this compulsion of I need to document everything the patient said and everything every nuance. And I think while admirable, that does not necessarily translate to great patient care. What is taking care of the patient, right? You get a good history, you condense it down to what works for you and what works in your thought process. And then you document, well, with this information, this is what I plan to do. And again, I keeping it concise for my own notes, and then you go on with your day. So I do think whenever you've seen the patient and then right after you document, instead of taking, as I said, previously, it took me 30 minutes to have to document a note, it's like 3 or 4 minutes.
Mm.
I will also say I made a point of saying, and again, you're very good at this. If a patient has a 20-minute appointment, that does not mean you have to give them all 20 minutes of yourself. I sort of said in my head, wouldn't it be great if I could wrap up this visit in 17 minutes, which will leave me 3 minutes to document? And I do think that is definitely something I've been trying to do very consistently since I joined the program. And I do think that makes a big difference. It's quality over quantity with a patient, I think, is just so important. But again, I think people equate quantity and quality as the same. And I don't. Sometimes that's a good thing, and sometimes that's necessary if you're having a hospice conversation, a cancer diagnosis conversation. Of course you want to spend time. But I think if it's just a diabetes checkup, you're giving quality care. It does not have to be time-based. So
Yeah, so different. If you look at you before and you now, that's a huge,
yes.
huge difference in time, like 30 minutes down to 3 to 4. Wowzers.
Yes. Yes. And of course, not every chart took 30 minutes, but
Yes.
I think we're curious people. So we're like, well, what did I do last time? Or what did that image show? And what were once you start going into you can go into the rabbit hole of the chart and
Mm,
look and try to
mm,
remember and things like that. And I think with the time pressure for me, and again, I don't know if this works for everybody, having that time pressure of having a waiting patient is the biggest motivator. And I think I have been able to use that as I got to get this chart done because I have a patient waiting in the next room. And that was a good motivator. I think perhaps for other people, I could see how initially that would be I can't chart, gotta go see the next patient. But I think having that motivator of the waiting patient has been a very good motivator for me.
yeah, so good. Tell me about the difference then in the possibility of pay. So when you're earning the money in the room with the patient and then you're charting it, documenting it days or weeks later, is that
Mhm.
significant?
Yes, absolutely. I would say in our particular hospital system, they talk about how they want the chart closed by the end of the month, for billing purposes. And so, you're right, if you have outstanding 10, 20, 50 charts open, then right, we don't get compensated on time. And I think that's a really important point that you are losing earning potential by not doing it. In the United States, we have, it's all about the work RVUs and, each encounter can generate X number of work RVUs. And of course, you want your numbers to be robust. Of course, I would hope most people go into medicine because it's a humanistic thing to do. It's an altruistic thing to do. But of course, it's a business and you want to keep your doors open and your lights on and your staff with you. And of course, it does come down to that you have to address the business side of medicine and that you do need to bring in revenue and income to be able to continue to care for these wonderful patients who need
Mhm.
you desperate to take care of them. So absolutely. Absolutely.
When you see a patient for 20 minutes in the clinic and then you spend a half an hour on Saturday charting it, does it get acknowledged in terms of pay, or is that now a volunteer position on Saturday?
No, because in America, when you code by time, it has to be of
Mhm.
that day that you saw. So, right, absolutely. If I see the patient on Tuesday and I spend half an hour on Thursday, I'm not allowed to document the time that I spent on Thursday. It's really the care you gave the day of service. So, yes, absolutely.
Okay, so by
Absolutely.
2 p.m. Saturday, that Saturday when you had this enlightenment, you'd worked all day for no money.
That's right.
Okay.
That's right. Or only for the little bit of whatever the E&M code that day. Right. Absolutely.
Oh yeah, getting the money from the
Abs
day that you saw the patients, that's important, obviously.
Right, but right. You
Yeah,
cannot, right.
but not
Absolutely.
the additional. I think that's important too, because we sometimes think that, well, it's not a day I would be paid anyway,
That's right. Mhm.
so I can just do it in my own time.
Uh-huh. Right.
But then you're
But
missing out.
what a slippery slope that is, though, right? And again, talking about work-life balance and, your wonderful podcast, sustainable clinical medicine, that's not sustainable, obviously. Like we all will reach a breaking point.
Mm,
The level of burnout so high among physicians, even, especially post-COVID. And then since, oh my goodness, so many conversations and discussions about physician burnout. And I will tell you, for me personally, this has significantly decreased my burnout. I have more energy when you have a difficult patient and you finally finish that chart, that cognitive load of that patient has left my brain.
mhm,
So when I go to the next room to see the next patient, my brain is just unencumbered in a big way. So when I see the next patient, I have so much more energy and probably more importantly, more compassion to see
mhm,
the next patient because I've left if it was an unpleasant or heavy or difficult interaction in the previous exam room, I go into the new exam room refreshed, you
mhm.
know, at least neutral, if not, you don't want to be negative going into your next patient, but at least neutral to at least positive and empathetic for the next patient. And boy, carrying the cognitive load of 14 geriatric patients throughout the whole day, I mean, you're going to approach the 15th patient of the day so differently, right? Versus say, if you've let go of the mental burden of the 14 patients before that 15th one. And I
Yeah,
do think, I don't know if people talk about that, but it's really you just go into it so much better. And I'll say too, when I see my patients now, they're not number 12 or 15, of course, your patient is a person and you want to address them as a person. And instead of already dreading, oh my gosh, this note is going to take me forever because this patient's complicated and they have a list of 20 complaints, you can just go in and be like, how are things going? Look, this is what you're doing well. And I will tell you, especially in geriatrics, when you tell a patient, I know you have a lot of these issues and you've struggled with this, but look at this, look at the nice things that you've been doing for yourself. Or I think you're doing great. Look at you, you're 85 years old and you're still here and you're still thriving. And I just have a lot more positive energy to give to my patients now. And I think they do benefit from it. When you can come into the room feeling, giving them your authentic, energetic self, it's a much better interaction for everybody involved. So,
that is so interesting and fascinating. I love that you're feeling better, so you can help your
mhm.
patients take a different perspective on their health than the dread and
Yeah.
gloom that you're feeling.
Right. Well, again, just like as talk about your thoughts lead to your feelings, which then can ultimately lead to your actions. So I do feel like I have tried to incorporate some of that into my patients. We all have those patients who are Eeyore, like,
Yep.
sad,
Yep.
depressed,
Mhm.
woe is me, I have so many problems. But if you can kind of turn it around for them a little bit, yes, you have this, yes, you have that, but look in this area. Your kidneys look much better now on your labs. Good for you for drinking more water. I do feel like we can coach our patients to a certain extent. Not to say that I'm not a trained coach in any way, but I do feel like there are a lot of what we do in medicine is coaching, telling them how to help themselves.
Yes.
And I do say that to my patients, like, I can't do this for you. I can't exercise for you. But boy, do you think you would feel better if you exercised a little bit more, using that sort of language
Mhm.
with that motivational interviewing? I mean, there's a lot of techniques that we as
Mhm.
healthcare professionals can for our patients. So,
Absolutely. I think that's such a
mhm.
valuable tool we can give out, even our ER patients. Even the ability to understand that this patient is an ER and that's just them. It's not a reflection on you, and how you are giving them information or helping them change. They're an ER. They're now 85 and they've been an ER their whole life, right?
That's right. Absolutely. And I do think we should celebrate the little wins that we get.
Mm.
And I do think that's an important. And I also think, like what you say too, when you talk about the powerful why, I think we can use a similar technique with patients. Like, is there a good, I do talk a, f- a sort of a non-medical thing I like to talk to my patients about is like, oh, what are your plans for this year? Do you have a trip? Do you have a goal? And I think we can use similar techniques, even with a geriatric patient. You can be
Mm.
like things like, I have a grandchild getting married in 3 months. Oh, well, isn't that wonderful? Wouldn't it be so great if you could do some
Mhm.
more walking so that when you go to the wedding, you will have a little more energy to do this? Or again, trying to find a good motivator for the patient, I think is a good way to help them with their whatever medical issues they're dealing with. So I
Yeah.
have tried to use some of that in my interactions. And I do think it's very positive.
Yeah, I really like that. You have two physician household. Tell me, was there any difference between how you and how husband was approaching the evening and weekend?
No, I have a picture somewhere I took a picture of my husband and I. We were both on our epics at like 9 o'clock on a Friday night, saying, "Oh, date night." And I am sure this is something a lot of other two-physician households. He works in a different hospital system, but he also uses Epic, and we're just both on our computers. This is our Friday night as a physician couple. He is an academic hospitalist. So he has advantages in that most often he has residents write the majority of the
Mm,
note. But again, he has perfectionist tendencies. He had to write his own note to, be sure his thought process is in there in case the resident didn't quite capture, the
mhm,
decision making went into it. So he spent hours doing a lot of charting at night as well. So, and I think I taught him techniques about, isn't it so much better when you just leave work at work and then when you come home, you're home and you don't have to mix the two. So he has been excellent. I would say too, I'm sure this is a struggle for a lot of physician families as far as a hospitalist, his schedule is erratic, it's unpredictable, there's weekends involved. Me as an outpatient doctor, thankfully my schedule is very regimented to a large extent, which is lovely. And so as far as taking care of our son, it's a good mix that
mhm,
we could switch off
mhm,
oftentimes. But
mhm. That might
yes,
have meant
many.
that you're doing a lot more of that housekeeping, meal preps, kid kind of
Mhm.
agenda pieces, if you're more in that 9 to 5 kind of space. That doesn't leave a lot of room for you back when we're doing evening charting too.
For sure. For sure. So yes, so no, that definitely took that was definitely on the back burner. I mean, thankfully, there were definitely pockets of time where our family of three could do fun things. We
Mhm.
certainly prioritize vacations. Um, and I would certainly encourage anybody to please use all your vacation time, your paid time off. I definitely hear of doctors who don't use up all their allotted vacation time, which I think is that I've never had a problem with.
Which
So I do. There's a work hard, play hard sort of dynamic that my husband and I are very good at doing. And so certainly, and thankfully I live in the wonderful state of Colorado. There's a lot of outdoor activities very close by to do. So we're very fortunate in that way. But I do think it's so important to have the work be work, your home be home. And I do think that's very just I can't tell you how just critical I think that is so that you can enjoy all of life. It is such a privilege to be a physician. It is such a privilege to have people trust you with their health and their vulnerabilities. But boy, that can definitely take a weight on you. I mean, that's a burden that is so, can be very heavy to carry. So
Mhm,
I do think I try to be very good with my boundaries of saying, letting that sink into my own personal psyche to a certain extent, but not letting it take over. And I hope for many doctors, they're able to make that strong boundary for themselves. And then again, when you come home, leaving the emotional toll of work at work so that you can be home and enjoy your family.
mm. It can be hard though, it's a process, like, 18
Yes.
years doing this one way
Yes.
and then having you said brave, I'm gonna be brave and do this, and it's a
Mhm.
big learning curve.
It is. It
It's
is.
a lot of
I feel
change.
also because I was almost at a crisis point, it made
Mhm,
me more open to change. And I can see for some people how maybe um you're kind of not quite at a breaking point, so you're like, maybe I don't need to change as much, but I do think they're just everybody has a different point where they're like, "Oh my gosh, this is just so hard." And I think then that's the moment where you have to be even more open to change. And I also think once you've done it for a little bit or you start to notice positive changes, even if you're not like, okay, I didn't get all of my notes done, but maybe I got 50% of my notes done, seeing how that changes how you feel and just have a little bit more energy to do things. I think that it perpetuates. It's a good positive cycle. And that's certainly how I felt for myself.
yeah, I love that. I love that it doesn't have to be perfect. It can be messy in the
Mm,
middle, that it can take a while, but
Excellent.
it's that progression towards what you want, and creating
Excellent.
that time for yourself outside of the medical day. Yeah. How do you think you left patients at work? Because even that can be a real struggle.
It is. And I do think partially having been a geriatrician now for 20 years, I do think I've had to learn. That is a skill I've had to learn. Um, how did I do that? That's a really good question. I think this is what I will say, especially for geriatrics. A different doctor took care of them for 65 years of their life. I got them after, say, they were 65. A lot of my new patients are 70s, 80s, even 90s, right? So I cannot have been responsible for all the medical care they received before they became my patient. And that was literally decades of
Mhm.
medical care. So when they come to me and they're already at advanced diabetes, end stage heart failure, COPD, whatever, I'm not going to fix. I can't fix. It's
Mhm.
impossible to fix those
Mhm.
conditions. But what can I offer them instead? So I feel like, what can I do to keep you comfortable? What can I do to give you quality of life? And 100% of the time, the patients say, I want quality of life, not quantity of life. So, what is in my toolbox of things to help you be comfortable? And it's little wins. It's like, hey, I don't think you need 3 blood pressure medicines. Your blood pressure's good. Let's take away one of them. Now we get you down to 2. And the patient's like, yay. Again, so many of us deal with polypharmacy and how, the med list that's so long. And
Mhm.
one of my favorite things to do as a geriatrician, let's take away this, what happens? Let's take away that, what happens? And oftentimes the patients do mostly okay. So the
Mhm.
patient's happy, I'm happy, their wallet is happy, they're not paying for as much. And so I do think, that's if the patient sees improvement or at least they're happy, then that makes me happy. And I can take that. The negativity I try to leave at work, but if they're like feeling positive, it's like, oh, I made someone's day a little bit better today. It wasn't a big change, but
Mhm.
that's, as we know, small changes do add up over time. So I do feel like if you can enhance their life in some way, even a small way, that's a good thing to take home with you. Not
Yeah.
you just have to the weight of the world, just you just, it's impossible to carry the weight of your whole patient panel.
Yeah.
That would be literally crushing. So
Mhm. I like, in reflection, I see that you kind of took that big step back and said, what is my role here? And
right.
yes, I have a patient who's got a disaster of a medical file. And
Mhm.
what's my position here and how can I best help my patient? And then you're finding evidence for how you're you're doing your best for each of
Mhm.
the patients who already arrive as a clunk, right? I call them clunks because they're just very complicated, they're advanced disease and sort of
Yeah,
thing, clunky patients.
right.
But your role, your identity as a physician within that relationship, and your evidence finding for how am I helping and how am I creating goals with this patient and helping them achieve their goals, even though I'm not addressing their disease, fixing their disease, or responsible for their disease. I think that's beautiful. Like, this is how you are able to say, you know what, I've got a panel of patients who are extremely unwell, and
Mhm.
I'm finding satisfaction within this job. And that
Absolutely.
fascinates the medical community. Some physicians I talk to that I could never do palliative care. It's all doom and gloom. I'm like, no, it's amazingly satisfying if you're in it
Very much.
for the reasons of, I can't fix the disaster, but I can be as helpful and professional and help the patient towards their goals. That gives hope, comfort, quality. Just like you said, I love that, Jane. It just helps people kind of put it in
Mhm.
perspective. Yeah.
Absolutely. I do think, again, especially for a lot of primary care doctors, we want to help so much, and we do, and we can do it in different ways,
Hmm.
but we can't fix. I mean, ultimately, it's so many of these conditions that our patients experience, they're not fixable. And
Hmm.
I think realizing that, understanding that, saying, oh, yeah, this is the patient, this is their physiology. There's
Hmm.
only so much you can culture in a patient's physiology, especially again as a geriatrician that had 80 years of their own physiology. I'm not going to fix that. So instead, taking a step back and saying, well, what can I help with? And again, I'm not going to be able to fix or
Mhm,
radically change certain, well, maybe there's certain things, but a
mhm,
lot of the time it's to comfort the patient. I let my patients vent, they're
mhm,
like, oh my God, I have this and I only see doctors all day, every day, and I only do this and and again, sometimes just letting them vent because they don't have anybody else to vent to. And you can just say, I hear you, I listen, oh, it is so hard what you're
mhm,
going through. But
mhm,
what can I do? And I literally say, what can I do to
mhm,
help? What can you think of something that I can do to
mhm,
help? And sometimes there isn't, and they know that
mhm,
too. But sometimes just being able to release some of that frustration that they're nervous to tell their children about or their other
mhm,
doctors about, and that's good enough for them. And again, I do think it's important for doctors to realize there are certain things you can fix. You can fix a UTI, a sinus infection, a broken bone. You can't fix the majority of things. They perhaps can't even fix it themselves, even with a better thought process or
mhm,
whatever. So my job is to comfort and be there
mhm.
and help when I can. And
Yeah.
I do think once you can get to that realization, I, I think for some doctors that could be, oh, well, that's sad. Why did I go through all this training? But I do think also, I feel like that is my job. That is my job to be like, and sometimes you have to get the patient to understand that too, and saying, I cannot fix this. The
Mhm,
cardiologist can't fix your heart. The
mhm,
pulmonologist can't fix your lungs. Sometimes I do have to be the bearer of that news,
mhm,
but I feel like 99% of patients, they want to be told that. They need that information. And
mhm,
then they can work on themselves to be more accepting of some of that.
mhm,
So sometimes I am the messenger who has to give bad, oftentimes I'm the messenger who has to give bad news, but nobody else has told them that.
mhm,
The specialist hasn't told them, oh, your heart is doing this or your kidneys are doing that. Again, we're so trained to try to fix, cure, treat. And again, totally noble, admirable. I hope a lot of doctors do carry a good amount of that, but I do think also as doctors, we have the responsibility to tell patients when we cannot
mhm.
fix, cure. There is a limit to our Western medicine at this time for many conditions. And so I do like to be the realist, but that
Mhm.
doesn't mean I can't do it with compassion, with empathy, with sensitivity, and meeting the patient where they're at too.
Yeah, I love that. So good. What do you look forward to now?
Oh, so that is an excellent question. Well, now my son is a teenager,
Mhm.
so with a lot of parenting journeys, when little kids, little problems, big kids, big problems. Not to say that my son is a problem
No.
as a teen, but when they're little, they're so caught up with, are they fed? Are they bathed? Are they clothed?
Mhm,
Are they, these? But now as a teen, there's a lot more emotional stuff. There's a lot more guiding toward their academic career. My son will be in high school soon. So I want to be available
mm,
for that. So I'm really looking forward to having those interesting, deeper, discussions around what do you see your, what subjects are you interested in? What do you see your career going toward? What do you, we
mm,
expect him to go to college and like, what do you think you're interested in career wise and things like that. So that's a very fun
yeah,
time. I do like this time that he's older and more engaged, and I want to be there until he becomes the surly teenager who doesn't want to talk to his parents anymore. So I want to be available to him
yeah,
to do that. So,
I love that.
uh,
Is there anything else that you have filled those hours with that may have been charting hours before?
Oh, yes. So I am definitely, thankfully, again, my husband and I like to do active things. We are avid bikers, hikers, rock climbers. We love to travel a lot internationally and domestically. We certainly have family who are in town. We have family in other parts of the United States. So being able to visit and do that is so, so, so important. And I will certainly say, for as a message to other doctors, I do not bring my computer on vacation. I do not check my messages. I leave work at work when I am on vacation, and I certainly encourage others to do that. I hear so many stories of doctors who are, even my own partners, they're like, "Can I see Epic from Spain?" I was like, "Why are you even trying to access your chart when you're on vacation in Spain?" So I'm like, "No, don't do that. Please don't do that. I don't think that's a good idea for you." So I certainly do encourage other doctors to take a mental break, physical and mental break from work when they are away. I do think I hopefully I try to model that for the other doctors that I work with a lot.
I
So
love that so much, so much. Any messages you would like to give, or anything that we didn't discuss that you'd like to discuss before we wrap up?
sure. Let me talk about just a few enhancements I have done in my clinical day that I think
Mm-hmm.
could help other doctors. One big one is the standing desk, and I did not think it was going to make a very big difference. But boy, when you have a standing desk, obviously you get to do a little more, a touch more physical activity than
Mm-hmm.
normal. But when you're standing, it is a motivator for you to finish that chart right then and there. Like you can't sit down, get comfy, be like,
Mm.
ah, now there's something about the standing that when and I dictate, and I hope I'm a very fast typer, but I'll still tell you dictation is faster. So
Mm.
I know people out there think they're fast typers, but dictation is very fast with Dragon. But when I'm there standing, Dragon, Dragon, dict the note, go on to the next patient. There's something about the standing that just keeps you in movement
Mm-hmm.
in a good way,
Mm-hmm.
personally. I definitely think for those who may have challenges with seeing a patient, sitting down at your desk and getting caught up in the inbox and the paperwork and the this. If you have a standing desk, it doesn't let you do that as easily. So
Yeah.
that has been an enhancement. Another thing we do in our clinic is something called Doctor of the Day, and this goes back to interruptions.
Mm-hmm.
Of course, there's times when nurses or medical assistants have to interrupt you with a UA result, an INR result, whatever. Each day, we designate one doctor to be that doctor to get all those interruptions. And they have they sort of have a day where it's slotted where they will have more time to
Mm-hmm.
deal with interruptions. So therefore, I do think that's very helpful to have one designated physician be the person, the point person for the random interruption. So if you have a clinic where you can structure it like that, I do say that that's a very helpful, helpful
Mm-hmm.
thing. So just some little clinic things that we do that I think we do very
Mm-hmm.
well. And we have a schedule where if someone has a day off or on vacation, that doctor is assigned to cover their inbox. And it's a schedule, it's predictable. And I do think in medicine, the more that's predictable, the more easier your clinical day goes. So
Yeah, certainly being able to know that you're going to have increased items coming in, so you can start to
right.
be prepared for that, whether it just be that you have an easier to eat lunch, right? Whatever it looks like, to be more knowing that your volume will be increased, and that they're patients you don't necessarily know well. So you have to kind of just
Right.
verify this is okay for this patient.
Absolutely. Absolutely. And so I do think that's a really good, having a schedule has been very helpful for our clinic
Mhm.
staff and the staff too. They know who to go to
Yeah.
instead of going down the line of, we all
Interrupting
sit in this
everybody till they
desk in
find
the
a yes.
That's right. So again, the staff also know who to go
Mhm.
to. They're not frustrated. They know, okay, today's the day that we ask this doctor for this. And so I hope it leads to a more harmonious clinic day for everybody involved. And I do
Mhm.
think the more, the smoother we can make life, the more sustainable our
Mm.
jobs are in general.
Another tip we do for covering inboxes, so I'm covering one of my colleagues at the moment as well, is that we have him have spaces in his appointment book for when I tell the staff that this person needs to come back to review this result with the doctor, so that I don't have to be the seer and doer. I can be the seer, and if it's urgent, I do, and if it's not urgent, I just put them into his block when he's back. And so I do the same for him. I leave a space where the staff only can book in for when he tells them, and so that just helps everybody get that inbox cleaned out faster, because you can simply look at it and say, it's not critical, but it should be reviewed. And so you just message the front and they put them into their calendar so that we have that as a continuity with the doctor for the patient. And you, the inbox looker, are just looking for danger,
Right.
return,
Totally.
or just tick it
Totally.
off. Yeah.
Absolutely. Absolutely. Yes. Oh, I love that. That's a really clever thing to know.
Yeah.
Yes.
Just
No, I know we all have
ideas.
these little pearls and tidbits that we can share
Yeah,
with
that's
each
right. The
other.
sharing of knowledge so that we all get home faster. Yeah.
Absolutely. Absolutely.
Well,
Well,
thank you
thank you.
so
You have been life
much.
changing. The other thing I forgot to tell you one more
Yeah.
thing. For our new physicians we
Yeah.
hire, we buy them your charting coach course because we want them to start doing well. So just so you
Yeah.
know, so that is something we've almost required for anybody who joins any new physicians. We say, we're buying you this charting course. I know you think you chart well, but trust me, you could do better. And so we're buying you this. You need to listen to it. You need to do it. And
Yeah.
so I certainly do think that that's something we have instituted because I have been such a proponent of how much my life has changed for the better of all the coaching that you do. So thank you for all you do because it's truly, I am trying to spread the word of your wisdom to all my other partners. So, and we'll
Okay.
continue to do so.
Thank you so much. I think that's just delightful that you can help your colleagues in such a practical way. So good. I mean, why wouldn't you want to work for Dr. Kim, right?
You're so
She's looking out for your evenings and weekends. I think that's like brilliant.
everybody wants that. Who doesn't want? Everybody
Right?
would want that.
Right? Who
So,
doesn't want their weekends and evenings back? All right. Well, thank you so much for this conversation. I really appreciate your time. Others will get value out of hearing your success and your changes that you've made. So I really, really value your time. Thank you so
I hope it
much.
helps. I hope
Have
it
a
helps
great day,
others.
everybody. See you next time. Bye.
Bye-bye.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.